I'm Dr. Debbie Martin. I run Martin's Vein and Medical Aesthetics Training Center in Barrie, Ontario. I've been doing that for about 10 years now. Love doing it, and there's a few things that I want to pass along to you that many people ask me. And that is, what are the biggest problems that you can run into if you're training for Botox? I have a Botox training video that goes through everything from the very beginning of anatomy and physiology and reasons why people want to have Botox, all the way through the planning of their treatment, the technique for treatment, and the potential complications that can occur and how you might deal with them. So I thought we'd start right off the bat from just talking about, well, what can go wrong with Botox and what value is there in learning about those things? Well, the good news is that although there are lots of common and minor side effects, there are very few side effects that are really going to cause a lot of grief for you or the patient. However, let me talk about a few of them. Perhaps the thing that I see most commonly that people have done is that they're trying to get a brow lift. So they're trying to get the brow a little elevated on each side to create a wider-eyed look. And the problem is that if the injection is done too far medially, then the injector makes the mistake of injecting frontalis by mistake of abicularis oculi. And that results in the exact opposite of what you're looking for. So if you're trying for an eyebrow lift, then you want to go a little further laterally on the eyebrow rather than medially, so that you will miss frontalis. If you hit frontalis, then you're going to get a heavy eyebrow and she will not be happy. Second, I think Spock eyes are probably the most common thing that goes wrong, and those are very easy to prevent, actually. So remember Mr. Spock from Star Trek? He had these eyebrows that came up on either side. So the story there is that if you Botox the glabella fully, and especially if you include a little bit of central frontalis, then you'll find that the only muscles that are really left are frontalis on either side, and that lifts up these eyebrows. Now, sometimes you can anticipate that that's what's going to happen, but what I usually do is see them at the 2-week follow-up visit, and then ensure that they do not have a peaked eyebrow on each side. Now, if they do have a peaked eyebrow, it's pretty easy to fix. All you have to do is put 1 or 2 units at the peak of that arch, which usually gets rid of your Spock eye. Now, of course, what you have to be aware about is that you don't overdo it, because that will create a lower eyebrow. Another common mistake that I run into is that people will be trying to inject the depressor anguli oris, which is a muscle that comes from here to here. They're trying to inject that guy, but unless they go a little bit further back, then they might come forward and inject the muscle that's directly in front of it, which is a lip depressor. If you inject that, then you'll get a funny looking lip and they'll complain of dysarthria. So my advice there is follow the DAO, go back a little bit, like maybe a half or a full centimeter back, and try not to go too far forward. If you go too far forward, you may run into dysarthria. Okay, so one of my pet peeves, it's not exactly an error, but a lot of people who inject Botox come all the way along the side of the abicularis oculi, and then they also go into the cheek here, and so they get into zygomaticus major. And yes, that will decrease the amount of lines that you get around the eye, but to my eye anyway, it looks as though it creates a ridge here, particularly if you're putting filler in the cheek. So the patient ends up with this big cheek, flat to here, and a ridge between the two. So my advice would be, stick with the abicularis oculi, really minimize the amount that you're putting into zygomaticus major, and be careful how much filler is going into the cheek. Okay, here's a mistake that I made on myself, to myself, and that was that we experimented a little bit with putting Botox in my upper lip, and I wasn't really thinking it through because I play the flute. So we were experimenting, and we put 1-1 on this side and 2-2 on the other side. And then, not even thinking about it, I went to band practice and tried to play my flute and came out like, recognizing at that point that you can't mess around with people who play woodwinds, or in fact people who sing. I'm also a singer. I'm not a great singer, but I do sing. I enjoy singing. And the issue is that your embouchure changes. So before you go injecting anybody around the lip, and even with the DAO as well, and maybe even considering the cheeks if they're a really important singer, like an opera singer, you don't want to do that, because you're going to mess with their embouchure and it will interfere with their ability to make a proper note. One more thing to look out for around the eyes is if you're going to inject abicularis oculi, please make sure that you're a good centimeter behind the orbital rim. If you go too close to the orbital rim, then the Botox could go right around the corner and interfere with lateral rectus. If it does that, then of course, if I were looking over to this eye would look fine over to this side, and this eye would still be looking straight because lateral rectus isn't working, which means now I've got diplopia, double vision, which is unacceptable, and in fact would make people, they would lose their license over that. You don't want that to happen. And the side effect that everybody worries about is having one eyelid droop down. Normally the reason for that is that one of your injections has leaked into levator palpebrae. We're trying to get it into glabella, maybe into frontalis, into the corrugators, but we do not want to get it into the levator palpebrae portion of avicularis oculi. If that happens, then that eyelid is going to go down, and it can stay that way for the full 4 months. The good news is that there is an antidote called apiclonidine that will work. If it's a true ptosis, then it will work. But you really don't want to be in that position. Ways to avoid that is staying 1 centimeter away from the orbital rim at all times. Do not let the patient manipulate the area. Be careful who you inject, because older people are more likely to have this problem. Their skin is much thinner, and so the likelihood of the Botox kind of distributing itself down into levator palpebrae is higher. And be absolutely sure that the patient is not going to lie down immediately after her treatment, because that will influence where the Botox is diffusing to and make it more likely to develop a ptosis. The other cause of, it's not a true ptosis, but the other cause of highbrow heaviness is just overdoing the forehead. I've run into way too many people who have had a whole lot of Botox in their forehead, and that takes away the only muscle that does any good heavy lifting up there. And if you can't lift up anymore, the opposite of that is to have a pulling down. And so the patient feels as though she has heavy brows, she gets headaches, she can't see properly. It's annoying and irritating, and believe me, you don't want a client who has that. Now, of course, all of these things go away after the Botox wears off, but you really don't have to wait around for those 4 months for something to wear off. You want to do a great job right off the bat, and then you want a client who's really happy, who's not only willing to come every 4 months to get more Botox, but is really comfortable referring friends and family.